Então, muito bom dia a todos. Cá estamos de volta para mais um dia de trabalhos da 17ª Conferência de VALOR APAH, focada nos cuidados de saúde primários. Antes de avançarmos para o primeiro painel desta manhã, chamo o Presidente da APAH, Dr. Xavier Barreto, para as boas-vindas.
Muito bom dia a todos novamente. Muito obrigado pela vossa disponibilidade, por estarem novamente aqui connosco. Quem esteve cá ontem sabe que temos um debate muito rico, com temas absolutamente centrais para os cuidados de saúde primários e que vai continuar hoje. Nós ontem discutimos mais Portugal, mais os problemas do nosso país, da nossa realidade, e hoje vamos ter uma perspectiva mais internacional e comparada com aquilo que estamos a fazer em Portugal. Sobre dois temas que são absolutamente centrais: recursos humanos, formação, distribuição, skill mix ou task shifting. Foi uma coisa que discutimos muito nos últimos dias. Como é que, de facto, organizamos as nossas equipas, e o acesso. É o segundo grande tema, sendo que estes dois temas relacionam-se muito, profissionais e acesso. Portanto, são os dois grandes temas, dois temas centrais para os cuidados de saúde primários e, em boa verdade, para toda a política de saúde em Portugal e no mundo. E, por isso, nós quisemos ouvir diferentes sistemas de saúde, diferentes colegas de outros países, para nos dizerem como é que estão, de facto, a garantir o acesso a cuidados de saúde primários nos seus países e o que é que podemos aprender com eles. No final temos um excelente painel, onde vamos ter as pessoas que começaram a reforma de cuidados de saúde primários há mais de 20 anos, quem esteve no terreno, a vertente política, mas também a vertente mais operacional, digamos assim, e quem está agora no terreno a continuar esta reforma. E, portanto, vamos ter um excelente painel que nos vai permitir perceber de onde é que viemos, o que é que nós queríamos há 20 anos, se estamos ou não a concretizar aquilo que planeamos e para onde é que vamos no futuro. Por isso, muito obrigado mais uma vez e até já. Boa conferência.
Então, assim avançamos, vamos cumprir precisamente isso. A primeira sessão é dedicada ao papel dos recursos humanos nos cuidados de saúde primários. Reúne um conjunto de oradores de referência, nacionais e internacionais, com percursos relevantes nas áreas da gestão, investigação e políticas de saúde. Ana Sofia Ferreira, consultora sénior da planeamento, Centro de Competências de Planeamento, Políticas e de Perspectiva. Professora, não se importa? Vamos subindo. Kuhlmann, consultora do Observatório Europeu dos Sistemas e Políticas de Saúde e do Parlamento Europeu, que se junta a nós remotamente. Peter Groenewegen, investigador em sistemas de saúde e cuidados de saúde primários e ex-diretor do Instituto Neerlandês para a Investigação em Serviços de Saúde. Professor, if you please. E Tiago Villanueva, médico de família da ULS Estuário do Tejo e presidente da União Europeia dos Médicos de Família. Dr. Tiago, por favor. Todos vão ter uma apresentação de 10 minutos antes do debate. Começamos com a intervenção de Kuhlmann. Dr. Ellen, can you hear me?
Yes.
Yes.
Can you also hear me?
Yes, very nice, thank you. We hear you very well. Hello, welcome. Thank you for joining us. So, eager to hear from you. Ready for your presentation, if you please. Não, é Ellen. Com licença.
Can I start?
Yes, please.
Okay. Thank you very much. So thank you. I'm so sorry that I cannot join you physically, but thank you for making this online participation possible. So my focus is on building capacity for resilient health and care workforce. And I want to highlight the need for institutionalization and for making it possible to govern a complex ecosystem in uncertain times. So now it works. So before I go into more details, I would like to acknowledge that what I'm now presenting is based on a collaboration with colleagues from the European Observatory on Health Systems and Policies. And also I draw on presentations that I already gave in the context of WHO Regional Office for Europe webinars. Why is institutionalization important for workforce stability and health system resilience? So institutionalization is really a key to ensure data and forecasting that lead to action. and that are capable to consider the dynamics in the health and care workforce, and not just only look at data that were relevant in the past. So strong institutions ensure that we can translate data and evidence into actionable policy, that we can build capacity for better data and competencies that are responsive to changing population needs, so aging societies, and especially also health security threats, heat protection, climate change efforts. These are examples that need to be considered in health and care workforce planning. And most importantly, also support for well-being and protection of the individual healthcare worker, because behind every healthcare worker is a person. We should never forget that. And finally, governance structures that ensure responsibilities and stakeholder involvement. So how to build these institutions that align health workforce development and health system reform? The pathways to effective institutionalization depend strongly on context and health systems conditions, and there is no one fits for all model. So it's important to at first look at the capacities that are available in the system, at the structures of the system, and then develop strategies on how to institutionalize workforce planning. And just as an example of a tax-funded national health system like in Portugal, institutionalization involves a central authority with direct control over planning that is able to link training, recruitment, and service delivery. Important measures are alignment between different sectors, so alignment between primary health care, social care, and community health care, and alignment between different professional groups. Also important is an embeddedness in legal framework and planning outcomes that are aligned with education quotas. Underpinning strong political support, research basis, sustainable funding, very important, are further important issues. And finally, an overall EU context and WHO recommendations can also be very helpful. How to develop these capacities? Capacity building is more than a tool. That is very important. It requires skills and infrastructures. And it requires also to critically revise the existing models, the existing planning models that were very much based on on data that reflect the past, and not the current situation and the future. Focusing on what we call the human side of the workforce, the needs of the individual healthcare workers, and responding more carefully to these needs. That also includes responsiveness to gender equality, to ethnic, sexual, and other forms of social inequality. So these are very important issues that are very often forgotten, as the health and care workforce is highly diverse and has diverse needs, and it is increasingly important to respond also to more vulnerable groups in the health and care workforce. Regional disparities are another important key issue that needs to be considered if we develop capacities. So in order to be able to improve the overall service delivery for the entire population, and linking national planning also to global and European framework. As we know, so national planning with growing migration and mobility and the EU free movement of people needs a more European approach. How to govern planning? Governance sets the rules for engagement of translating evidence into practice. So if we want to improve planning, it always requires looking at governance, because governance is really a key where we can make changes, where we can improve the efficiency and efficacy. So strong leadership and multi-level participatory governance is key issues to foster the implementation, engage diverse stakeholders, professional bodies, unions, training providers, and all these. How to translate evidence into practice, the key issue. So policy dialogues might be an important tool that serve as a bridge between policy and practice, and that are capable to bring different stakeholder groups together in a friendly environment, and to improve the discussion, the knowledge sharing, exchange between different stakeholder groups and different sectors. Expanding of stakeholders and strong participatory approaches need intersectoral and multi-professional coordination. And I think all healthcare systems are struggling to some extent with fragmented professional kind of silos. And this is historically grown by the development of professions, but it's very important to counteract that and to build multi-professional structures that are more capable and more responsive to the needs of teams and the needs of contemporary service provision. Participatory governance must also be gender responsive and transformative to reduce the existing inequalities. Gender is one key issue, but it's also important to integrate migrants, refugees, older professional groups, also increasingly important when looking at the structure of the health and care workforce. So, of course, also younger, early career health and care workers must be integrated. Key policy recommendations. Assess health reform and policies through the lens of health workforce stability and integrate needs of the individual professionals. Understand the core benefits that the health and care workforce, it is not only a cost, it is first and foremost a benefit and a strategic way of improving, investing in health and care. So it is a benefit for the health and society. Understand that gender equality is a strategic approach and a key condition for improving workforce stability, as about 75%, maybe even higher in some areas of the health and care workforce are women. And discrimination is still strong on various levels, also wage discrimination. Establish legal frameworks and appropriate funding to anchor the institutionalization of planning in health systems, and to connect primary hospital and community care and the diverse professional groups that are involved in providing this care. So finally, workforce planning must move from a technical procedure towards the governance of a complex ecosystem in increasingly uncertain times. Thank you very much.
Thank you, Professor. Please stay with us. We will return to you soon. And now we are going to listen to Ana Sofia Ferreira, consultora sénior da planeamento. Por favor, professora.
Então, muito bom dia. Ouvem-me bem? Sim? O meu nome é Ana Sofia Ferreira, eu sou economista da saúde e sou administradora hospitalar, portanto é esse o meu background, não sou médica. E tenho estado, portanto sou do SNS, tenho estado nos últimos 3 anos no PlanAP, tenho tido o privilégio de estar a estudar, coisa que nós quando estamos na administração hospitalar nem sempre temos tempo para fazer, estudar algumas das realidades que nós sentimos no terreno, nomeadamente relacionadas com a força de trabalho, com os recursos humanos do SNS. E, portanto, vou-vos trazer aqui alguns dados. I'm sorry for not speaking in English. I was not prepared to speak in English. To do it on the debate, ok. Portanto, vou-vos trazer aqui alguns dados sobre a realidade portuguesa no que toca à força de trabalho dos cuidados de saúde primários. No fundo, a questão que me moveu quando fizemos este trabalho foi perceber até que ponto é que, na realidade daquilo que são as características e a evolução do contingente de profissionais dos cuidados de saúde primários no SNS, está ou não traduzida uma prioridade política dada aos cuidados de saúde primários enquanto componente central da política de saúde, ok? Chamar-vos aqui a atenção para o facto de que nós estamos apenas a focar o SNS, ok? E estamos a utilizar dados do payroll, do sistema de pagamento dos profissionais, do RHV. Portanto, é uma amostra relativamente limitada. Nós, em Portugal, não temos informação sobre todos os recursos humanos do setor público e privado. Ou melhor, essa informação existe, mas não está trabalhada, nem está regulada de forma a que possa ser estudada de forma compreensível e, portanto, o único olhar seguro que nós temos em termos de data access, não é, é aos dados do RHV e dos cuidados de saúde primários do SNS, neste caso. Portanto, nós, no que toca aos cuidados de saúde primários, há duas formas de olhar para os dados. Headcount, portanto, número de profissionais, ou equivalentes a tempo completo, que nos dá uma carga de horário de trabalho disponível. Não é correto, como muitas vezes fazemos em dados oficiais, olhar para os dados em termos de contingente de profissionais, porque nós temos muitos profissionais com horários reduzidos. Portanto, temos que olhar para os dados em termos de equivalentes a tempo completo, que são estes que estão aqui, os tais ETCs. Aquilo que se verifica é que entre 2017 e 2024 os ETCs totais dedicados aos cuidados de saúde primários têm diminuído. Vamos ver isso aqui melhor mais à frente. De uma forma geral, e aqui neste gráfico estamos a olhar para os ETCs do total do SNS, portanto, no que toca ao total do SNS, incluindo cuidados hospitalares, o número de profissionais medido desta forma tem crescido, embora em equivalente a tempo completo tenha crescido a um ritmo inferior ao headcount, o que significa que os profissionais têm cada vez maior tendência para pedir horários inferiores ao horário completo, ok? Aquilo que se verifica é que já antes do Covid, da pandemia, houve um crescimento relativamente marcado, que teve muito a ver com a recuperação das 35 horas, que tiveram um grande impacto, sobretudo no pós-troika, não é? Voltámos das 40 para as 35 horas de trabalho, tínhamos estado com as 40 na troika e depois regressámos, e teve muito a ver com o impacto até na profissão de enfermagem, que é aquela mais prevalente no contingente dos nossos profissionais. Depois, com o Covid, houve realmente um aumento significativo e aquilo que talvez seja particularmente surpreendente é que no pós-Covid nós temos aqui uma marcada desaceleração ou estagnação. Portanto, a ideia de que os profissionais no SNS têm estado a aumentar de forma estável e sustentada, nos últimos anos não tem adesão à realidade, ok? Nos últimos anos, aquilo que nós verificamos em equivalentes a tempo completo é que o contingente total de profissionais que trabalham no SNS tem estagnado ou até reduzido ligeiramente por comparação com 2022. Claro, também houve aqui um efeito ainda por cima das parcerias público-privadas que foram integradas na folha de salários, digamos assim, esses profissionais do SNS e, portanto, no início do período nós não tínhamos aqui os profissionais dos hospitais de Vila Franca de Xira, Braga e Loures e no final temos, portanto, ainda há esse acréscimo que enviesa um bocadinho os dados. Portanto, o crescimento ainda é menor do que aparentemente parece. Todavia, quando olhamos apenas para a fatia dos cuidados de saúde primários, nós conseguimos segmentar os cuidados de saúde primários nestes dados porque nós temos os dados dos recursos humanos por centros de custo. E, portanto, mesmo quando estamos a falar do LS, conseguimos classificar se aquele centro de custo pertence ao setor produtivo dos cuidados primários ou ao setor produtivo dos cuidados hospitalares. E, portanto, quando segmentamos aquele total e olhamos apenas para a realidade dos cuidados de saúde primários, aquilo que verificamos é que a força de trabalho em equivalentes de tempo completo desde 2021 que não tem crescido, ok? Dito de outra forma, no que toca à estrutura do total de profissionais, nós tínhamos cerca de 22% do total de profissionais do SNS em 2017 alocados aos cuidados primários, quando em 2024 já temos apenas cerca de 18%, o que, enfim, só por si é bastante revelador da prioridade dada a este setor. Há aqui uma ressalva, todavia, que eu tenho que fazer, que é o facto de, nestes anos recentes, parte dos profissionais, nomeadamente nos cuidados primários, passou para a responsabilidade das autarquias. É uma parte muito limitada, nós não temos dados oficiais sobre esses contingentes e, portanto, temos que trabalhar com os dados que temos, não é? Em todo o caso, se perdemos informação sobre eles, isso também é revelador da prioridade política dada ao olhar global sobre o que se passa neste setor, não é? Porque não devíamos ter perdido. Pronto, nós conseguimos fazer aqui uma análise por grupo etário, por género, por região, por grupo profissional e por setor de cuidados, porque temos os dados do RHV, embora anonimizados, com todas as características sociodemográficas de cada profissional, e podemos começar por olhar para os grupos profissionais. Portanto, no SNS, este slide refere-se ao total do SNS, nós verificamos que temos crescimentos em todos os grupos profissionais, de uma forma geral. Verificamos também que o grupo de profissionais mais importante do SNS, em termos de prevalência, são os enfermeiros, logo seguidos, não dos médicos, mas dos assistentes operacionais. Portanto, uma massa enorme de profissionais que nós normalmente ignoramos e que não consideramos e que, na verdade, é muitíssimo importante e absolutamente essencial para que os serviços funcionem. Em terceiro lugar, temos os médicos especialistas e depois, depois temos ali também os assistentes técnicos e os médicos internos. Claro que se somarmos especialistas e internos, os médicos em si, não é, no seu total, são o segundo grupo mais prevalente. Eu não quero dizer mais importante, porque depois isso tem sempre leituras, enfim, subjetivas, mas o segundo grupo mais prevalente é o dos médicos e portanto, confirma-se a centralidade dos enfermeiros e dos médicos. Quando olhamos para os cuidados de saúde primários do SNS, há alguns factos muito importantes. Reparem, aqui todos os grupos crescem, de um modo geral. Quando olhamos para os cuidados de saúde primários, já não é exatamente assim. Reparem no que sucede aqui ao grupo dos médicos especialistas, portanto, este azul escuro, ok? Nós, no final do período, temos menos médicos especialistas em ETC nos cuidados de saúde primários do que tínhamos em 2017. Isto diz muito sobre as dificuldades que estamos a viver recentes, não é? Enfim, os últimos dados que temos são de 24, sobre aquilo que se passa. Temos, enfim, mais morbilidade, mais envelhecimento e, no fundo, a gestão clínica, médica, direta destes cuidados está com mais dificuldades do que estava no início. Não vou aqui entrar em muitos detalhes, apenas dizer-vos que, de facto, confirma-se que aqui nos assistentes operacionais terá havido aqui alguma passagem para os municípios, não é? De qualquer modo, nós não conseguimos exatamente perceber o que é que se passa com esse grupo de profissionais. Um aspecto essencial, aliás, a professora Ellen abordou a questão das gender inequalities, tem a ver com a composição por género dos profissionais do SNS que trabalham nesta área dos cuidados primários. 4 em cada 5 profissionais dos cuidados primários no SNS são mulheres. Este aspecto não é indiferente em termos de policy design, não é? Porque nós temos ainda persistentes desigualdades de género no SNS. Eu não trouxe esses slides, não tinha tempo, mas há uma publicação que o Planap, que eu coordenei, que o Planap lançou, sobre questões de género, trabalho e liderança no SNS, em que nós verificamos não só que temos uma menor proporção de gestores face à massa gerida de profissionais do que a média da economia, portanto, nós temos escassez de dirigentes, de pessoas dedicadas à gestão no SNS por comparação com a economia média, sendo que o SNS é uma fábrica bastante mais complexa do que as fábricas, entre aspas, da economia média. E temos também uma questão muito séria e mais séria do que na economia média, do que na economia em geral, nós comparamos com dados dos quadros de pessoal, no que toca à ascensão a posições de liderança. Portanto, é mais difícil uma mulher ascender a posições de liderança dentro do SNS do que ascender a posições de liderança fora do SNS, sendo que, em geral, para as mulheres, ascender a posições de liderança, seja onde for, é muito mais difícil do que para os homens. Portanto, o que é que isto significa? Significa que muitas vezes as instituições, e como ainda há desigualdades de género marcadas, não é? Na sociedade portuguesa, como todos sabemos, não vou entrar por aí, porque isso é evidence-based established, aquilo que acontece é que muitas vezes as políticas que são desenhadas por, maioritariamente, homens, não têm em consideração muitas das dificuldades de conciliação da vida profissional, da necessidade de adequar turnos, da necessidade de adequar horários e durações de turnos, da necessidade de haver creches, se calhar, disponibilizadas pelas próprias instituições, que tudo isso dificulta e torna a vida profissional nestas instituições muito mais complexa e muito menos apelativa do que poderia ser se estas questões específicas de género fossem tidas em causa. De qualquer modo, só para saberem, a taxa de feminização é sempre superior a 60% em qualquer grupo profissional, e se excluirmos o grupo dos médicos, que apesar de tudo é aquele que tem maior prevalência relativa de homens, embora seja predominantemente feminino, é sempre superior a 75%. Portanto, temos de facto que ter um olhar muito fino para isto, e convido-vos a lerem a tal publicação sobre enviesamentos de género na ascensão a posições de liderança que o Planap tem na sua página. Relativamente às questões etárias, o envelhecimento dos profissionais no grupo dos cuidados primários, curiosamente, não é tão mau como no SNS em média, ok? Nós não temos aqui os dados do SNS em média, não tinha tempo de discutir tudo, mas para terem noção, nós nos cuidados primários, mesmo assim, 6 em cada 10 profissionais, portanto 60% dos profissionais têm mais de 45 anos, não é? Não é que sejamos propriamente idosos, mas isto tem impacto numa série de questões de disponibilidade, porque, nomeadamente, as obrigações de prestar trabalho extraordinário, etc., estão limitadas pela idade, como todos sabemos, mas tem também implicações em algo muito importante, que é o absentismo. O absentismo nós estudamos, há outra publicação do Planap dedicada exclusivamente ao tema do absentismo, é um estudo grande, também os convido a ler, ele também está segmentado por cuidados primários, por setor produtivo, etc. Aquilo que nós verificamos é que os dias úteis de ausência dos profissionais têm uma relação linear com a idade, e, portanto, à medida que os profissionais envelhecem, faltam bastante mais do que os profissionais jovens, embora os jovens faltem por motivos relacionados com a parentalidade, nos mais idosos faltam sobretudo por motivos relacionados com a doença, e isso significa que a carga de pessoas disponíveis, quanto mais velhas somos, embora o headcount possa ser o mesmo, em termos de disponibilidade para o trabalho, ela reduz consideravelmente. Portanto, há aqui um problema de envelhecimento potencial da própria força de trabalho que tem que ser tido em conta. No Planap também tínhamos dados que eu acho particularmente interessantes, e espanta-me que eles não sejam trabalhados de forma mais fina por especialidade médica. Portanto, eu peço desculpa se houver aqui enfermeiros. Não sei se têm noção, nós não temos informação oficial sobre as especialidades de enfermagem, embora, se eu quiser saber, de repente, quantos enfermeiros especialistas tenho em enfermagem médico-cirúrgica ou em saúde mental, não tenho forma automática de o saber, mesmo no RHV, porque essa informação, como não contava para a progressão na carreira, não era compilada de forma fiável. Ok? Mas temos sobre as especialidades médicas, portanto eu não consigo olhar para as especialidades de enfermagem, mas consigo olhar para as especialidades médicas. E há aqui alguns aspectos muito interessantes, só chamar-vos a atenção aqui para isto. Portanto, a medicina geral e familiar representava neste ano cerca de 27% do total de ETCs médicos, ou seja, sempre que nós falamos em conceber políticas dirigidas aos médicos, mais de um quarto destes médicos são de medicina geral e familiar, portanto nós não... E nós sabemos também da sociologia médica que conceber medidas dirigidas a internistas ou a médicos de medicina geral e familiar não tem nada a ver com conceber medidas dirigidas a anestesiologistas ou a cirurgiões gerais, não é? Peço desculpa, vou voltar aqui atrás. Os interesses, as vocações, os incentivos pelos quais se movem diferentes especialidades médicas são completamente distintos, não é? Bom, o que é que interessa aqui realçar? Primeiro, metade dos médicos do SNS estão concentrados apenas em 4 especialidades: medicina geral e familiar, medicina interna, pediatria e anestesiologia, ok? Portanto, quando falamos em conceber políticas dirigidas aos médicos, temos que ter isto em conta, são especialidades muito diferentes. E a segunda especialidade relevante nos cuidados primários, que é a saúde pública, está aqui em baixo, ok? Vem em 13º lugar. E quando chegamos à saúde pública temos 75% do total dos médicos, ok? O que é que nós verificamos ao analisar a diferença de ETCs médicos por especialidade neste período? Verificamos primeiro que a diferença era completamente diferente, era completamente dispar entre especialidades, ou seja, Há especialidades nestes anos que cresceram muito mais em ETC do que outras. Isso é muito diverso por região do país. O crescimento é muito mais intenso nos cuidados de saúde hospitalares do que nos cuidados de saúde primários, portanto tem claramente havido um reforço da força de trabalho médica nos cuidados hospitalares, mas não nos cuidados primários. E há um conjunto de especialidades transversais, eu acho que isto é particularmente importante, como a anestesiologia, a radiologia, etc., que têm tido um crescimento de muito menor intensidade do que as outras, o que significa que as especialidades médicas transversais que dão apoio às outras especialidades médicas têm ficado cada vez mais carentes. E isso leva a que num hospital, nós se quisermos dar alta a um doente que está na medicina interna, mas precisemos de um gastroenterologista ou de um radiologista para fazer uma endoscopia ou o que quer que seja, vamos ter mais dificuldades e vamos ter mais protelamentos de alta. Se precisarmos de mais anestesiologistas para dar vazão a mais cirurgiões gerais que temos, mas que não temos depois os anestesiologistas para dar vazão no bloco operatório, vamos ter mais adiamentos de cirurgias. Portanto, este crescimento desequilibrado das especialidades é muito pouco saudável. E isso leva-nos à questão que eu deixo aqui em baixo, que é, afinal, que políticas de formação dirigidas e de retenção é que estamos a ter para este tipo de especialidades médicas. Dar-vos nota também que nestes anos a medicina geral e familiar perdeu peso na estrutura. Em 2017 nós tínhamos cerca de 31% do total dos médicos como médicos de medicina geral e familiar. Em 2024 são apenas 25,5%, está bem? Não vou aqui entrar em detalhe nas outras, apenas dizer aqui que na saúde pública, que está cá em baixo, cresceram 0,1 pontos percentuais, graças ao Covid, provavelmente. Por região de saúde, dar-vos nota também que nos cuidados primários, em geral, o único crescimento que se tem notado é no Algarve e alguma estabilidade na região norte, mas, portanto, também bastante desigualdade por região, não há uma uniformidade. E algo que me parece particularmente importante, eu não tenho a certeza se ainda tenho, acho que já estou a ultrapassar o meu tempo, mas dar-vos nota aqui muito rápida destes aspectos. Portanto, quando consideramos o total dos profissionais do SNS, incluindo os cuidados hospitalares, interessa-nos relacionar com a população e, portanto, nós calculamos densidades populacionais, profissionais ETC do SNS por 1000 residentes e aquilo que verificamos é que, por região, as dinâmicas de crescimento são muitíssimo diferenciadas. Vejam, por exemplo, o que acontece com o norte, não é? Que no início do período começa cá em baixo e ao longo do período consegue saltar para meio da tabela. Há um período de estabilização dos rácios ali a meio da tabela e depois aquela parte final em que já há algum decréscimo e alguma estabilização dos profissionais do SNS, vimos isso no gráfico anterior. Interessa aqui também dizer que no início do período a divergência entre as regiões era ligeiramente maior do que no final do período. Mas nos cuidados de saúde primários não é isso que acontece, ok? Nos cuidados de saúde primários os rácios pioram em todas as regiões, exceto na região do Algarve, está bem? Portanto, mais uma vez, a evolução nos cuidados de saúde primários é pior do que a evolução da média do Serviço Nacional de Saúde e continuam-se a verificar marcadas desigualdades regionais na distribuição dos profissionais dos cuidados de saúde primários por região, sendo que no final do período ela é mais marcada do que era no início do período, ao contrário do que sucede para a globalidade dos profissionais do SNS. Portanto, há aqui várias tendências bastante preocupantes. Se isolarmos os médicos de medicina geral e familiar, o panorama é ainda pior, está bem? Portanto, eu começo das notícias más para as piores e para as realmente graves, está bem? Aquilo que verificamos aqui é que apenas a região do norte, eu aqui em cima escrevi em todas as regiões, peço desculpa, na verdade é em todas as regiões, exceto na região norte, que está mais ou menos estável, mas ainda assim melhora um bocadinho, portanto é a única que recupera um bocadinho em médicos de medicina geral e familiar, todas as outras pioram. Vejam bem a gravidade da situação de Lisboa e Val do Tejo, que está muito pior em 2024 do que alguma vez esteve. Ok? Portanto, quando falamos nos problemas da região de Lisboa e Val do Tejo, estamos a falar de outro país. E é um bocadinho contraditório porque normalmente as capitais dos países têm menos problemas do que o resto do país. Aqui é precisamente o oposto e temos que estar muito conscientes disto. Só para vos dar aqui nota do que é que isto significa em termos de contratação de médicos necessária. Nós não sabemos quantos médicos de família precisamos, porque nós não fazemos estudos prospectivos no SNS, infelizmente. Não temos como dizia a professora Ela, não temos um conjunto de instituições dedicadas ao planeamento, não temos aquela institucionalização robusta que planeia, que planeia a formação, que planeia a alocação, que planeia a retenção. E, portanto, vamos fazendo isto um bocadinho ad hoc. Não sabemos de quantos precisamos, mas sabemos qual é a região melhor colocada. A região melhor colocada é a região norte, não é? Temos aqui. Portanto, o norte ficaria igual a si próprio e precisaria de contratar 0 médicos. As outras regiões, para ficarem iguais à região norte, precisariam de contratar os médicos que estão ali, sendo que Lisboa e Val do Tejo era quem precisaria de contratar mais médicos para se equiparar ao norte. Convertendo aqueles 944 equivalentes a tempo completo em número de profissionais, precisaríamos de contratar 1030 médicos de medicina geral e familiar só para equalizar as regiões. Portanto, não quer dizer que ficássemos bem, mas ficaríamos todos iguais face à densidade populacional. Ok? Espero não estar a ser muito rápida. Bom, vou ter que saltar estes slides da satisfação e retenção, porque não vamos ter tempo, mas dizer-vos apenas, para fazer um bocadinho a ponto com o que nos disse a professora Ellen no início, é que não é possível fazer planeamento sem conhecer a realidade. A realidade em Portugal é muito dispar, não é? Portanto, nós não temos nenhuma homogeneidade no país, embora o país seja muito pequeno, no que toca à distribuição e às características da força de trabalho dos cuidados de saúde primários, nem do SNS em geral. Há também um estudo comparativo do Planap com a região autónoma da Madeira, autónomo deste que vos estou a apresentar, que vos convido a ler porque demonstra que nós temos mais recursos humanos por habitante na região autónoma da Madeira do que temos no SNS, ao contrário do que poderia ser expectável, porque falamos sempre dos problemas de insularidade. E há um estudo muito recente, que também não está aqui citado, em que nós comparamos os recursos humanos do SNS com os recursos humanos do National Health Service, inglês, e em que percebemos que no National Health Service temos praticamente o dobro dos profissionais por habitante e, sobretudo, um grande mix, uma muito maior diversidade em termos de skill mix de profissionais e de profissões auxiliares do que temos no SNS. Portanto, isso são inspirações para este conhecimento relativo da realidade que enfrentamos, mas queria concluir dizendo apenas, não é possível desenhar um futuro para os cuidados de saúde primários sem fazer planeamento. Para fazer planeamento nós temos que começar por fazer previsão de necessidades. A previsão das necessidades radica na epidemiologia e radica nas características da população. Portanto, nós temos que prever estas necessidades não só em termos de quantidade de recursos humanos, mas sobretudo em função das suas competências. Okay? Porque nós estamos cada vez mais velhos, nós cá não precisamos de tantos neurocirurgiões, nem de tantos, enfim, anestesiologistas, não quero dizer aqui nenhuma coisa que me vá levar a uma primeira página de jornal, mas precisamos de muitos anestesiologistas, precisamos de muitos médicos de medicina geral e familiar, precisamos de muitos internistas, precisamos de pessoas com vocação integral para tratar pessoas idosas, que é o que estamos todos a caminhar para ser. E depois precisamos de fazer coisas muito importantes que não estamos a fazer. Adequar a formação de profissionais. Nós temos falta de formação médica. Há formas de demonstrar isto, ao contrário do que por vezes se diz. E precisamos de gerir as contratações no SNS, porque é a parte solidária do sistema, não é? A parte privada do sistema é importante, mas não é a parte solidária do sistema. Portanto, na parte solidária do sistema de saúde, nós temos que adequar a gestão das contratações de forma alinhada com as necessidades, que não estamos a fazê-lo, e temos que implementar estratégias para reter os profissionais e para que eles se sintam saudáveis no exercício da sua profissão, que hoje também não estamos ainda a conseguir fazê-lo. O estudo de satisfação que temos também publicado, nós já temos 8 ou 9 estudos publicados, tem muitos indicadores sobre isto, também os convido a ler isso e a explorar isso, está tudo no site do Planap, está bem? Muito obrigada e foi um gosto.
Peter, if you please. Please.
Where is the... Okay, yeah.
Okay, so this is forward,
Yeah.
backward.
Yeah, okay. Bom dia. I apologize to having to do my talk in English, but I console myself with the idea that when you would have been in the Netherlands for an audience of primary care planners, you would have the same difficulty, I guess. I'm a health services and health systems researcher. I've been doing that for the past 50 years, and including workforce issues, of course. I had a side hobby in research into environment and health in the 1990s and early 2000s. And what you see is now that issues of environment and health are becoming internalized in the health system. There's these movements towards green general practices, for instance. So that's nice to see. My other side hobby is health of prisoners and their families. And I'm doing research at the moment in these areas. And that is also very important for primary care. Every GP has some patients at some point that are in prison, and more family members that have someone who is in prison. So that's, and I'm not a medical doctor, I'm a sociologist by training. So that as an introduction. I will tell something about the workforce and especially the needs for a transformed workforce given the challenges on the healthcare systems and the proposals to change that. It is largely in a policy brief that I wrote with two of my Nivel colleagues for the European Observatory. At the moment I made these slides, it was not officially published, so I got 2 conference copies. I still have them with me. I thought, well, I'm going to make a lottery and then, well, but earlier this week it is published, so you can just go to the website of the European Observatory and download it. But I need to get rid of my 2 copies. I don't want to bring them back. I'm going to say just a few things about the supply problems in primary care, but more about the issues of increased demand and how we have to cope with that. The decreased supply, it's of course an important issue of demography. The demography of the primary care workforce. You just showed these changes, and it is something that is important in all countries in Europe, although the actual aging differs, but it's always seen as a problem. And maybe at the background of that is that it is seen as a problem. We all know that it's not easy to do something about it, so you can just go on. But of course, the reaction would have to be, what can we do to mitigate these changes and what policy transformations are possible? Another issue of well, you showed the feminization of the workforce. That is a very important demographic change that had big influence. In the past, say 40 years ago, a GP was a man and his partner was supporting the practice as in the role of a nurse or a secretary. So that was easy. But now, the majority of GPs are women with a partner who has worked somewhere in the service sector usually, or the economy sector. And so the decision where to start practice or to stay in practice is not anymore an individual decision of this male GP and his wife following, but it's what I would say a household decision. And if you look at the literature on retention, for instance, it's always about the intention of professionals to leave the profession, but it's never about how this decision comes into being in the interaction between a person, his or her partner, the role of the children. So that's an important one, I think. We should do that in our research and look more at that also. The imbalance was also very clear here, and that is also strange that even in small countries, like a densely populated country like the Netherlands, there is still these issues of disparities between remote areas and more central areas. So it's all relative. The distances are not as big as in Norway, but the problems are perceived more or less as the same. These problems in remote and rural areas are very intricate. the population is declining, the service level is declining, there's an aging of the population because people move for their education and work to other places, leaving the older people behind in a situation of less services available and problems of isolation. And on the healthcare supply side, there's this whole situation of the job situation for people's partners, the professional interactions that they can have, access to medical education, continuing medical education, etc. So leading to a low supply of primary care and imbalances in the countries. But I said I would go more into the side of the demand. There is an increased demand for healthcare with an aging population, multimorbidity, and so on. There is people who think that we can reduce demand through prevention and healthy aging and these kind of policies. Of course, that is true, but it will take a long time. And there's one certainty: we're all going to die, and the most care-intensive part of your life will be the last year of life. And if there's something we cannot abolish, it's the last year of life. So whether we get older or not, it stays. The other side of addressing increased demand is increasing the efficiency through new ways of delivering care. Alexander Gouveia showed yesterday this whole movement of digitalization, and he also showed that we can be optimistic about it, but there can be a paradox in it. But digital care is one of these policy lines. Increasing integrated care, patient self-management, with the risk of individualizing people's situation too much and putting the responsibility at the individual, where the basic causes are probably much more societal, and increasing the collaboration with family, caregivers, volunteers, and community services. And what we did was, starting from this, we took a number of care models that are described in the literature, ranging from population health management to case management and everything in between. And what we looked at is the main target populations, the sector of care delivery, and what kind of professionals do you need in these situations. I will not go into the details of this, but go to the more abstract workforce requirements. And the first thing is that transforming care requires transforming the health and workforce. You cannot change the health system without also addressing the workforce, something that Alan Kuhlmann already emphasized this morning. And if we look at the workforce requirements, we see three broad competency domains. There are the specific competencies that are, for instance, required in a digitalizing healthcare situation. So digital literacy, not only of the workforce, but also of the patients, of course. If you look at population health management, the data analytics that are so important to use the integrated data, to integrate the data for a whole population, the integrative care planning. Then, apart from these specific competencies, there are probably as important or more important the generic or transversal competencies that have to do with collaboration, communication, teamwork, shared decision-making, all these things that bring the parts of the system together, from the team level to the regional level and the national level. And leadership competencies to manage change and to manage also the collaboration between the different sectors. And what we found is that in all these new care models that are, so to say, the saviors of our healthcare systems, there's a central role for primary care. In all these innovative care models, nurses and GPs are crucial. The primary care should move towards a much more people-oriented approach. And I use the word people because that both implies patients, the person-centered care, but also the approach to the whole population, the population management side of it. Outreaching care and community-based care. The models also imply broader roles for nurses. If you look at it over Europe, the roles of nurses are hugely different, but also the education is, of course, more different than the medical education, but there are still countries where nurses are supposed to support the doctors and not the patients. And so there should be a move away from supporting doctors to supporting patients, and that means that they need different skills and being given the responsibility to do their own patient contacts and consultations. And finally, we need an innovative and learning healthcare system. And that means that there needs to be management and administrative support, because otherwise there is no way of using the information that is in the system to learn from. And in particular, in countries with small units for general practice, like in the Netherlands or in Austria or in Germany, you need something like a small front office and a large back office. The small front office is important because research shows that what patients really want is to have primary care close to their homes with a trusted face and say the person of the GP. And that is very difficult in the huge practices that we now see in the UK, for instance, where you have over 15 GPs. And imagine that also in rural areas. The distances are huge, of course, for people. And the elderly people are in these rural areas have difficulties to access. So what you would want to have is that in the access process, it looks as if a very small organization, but at the back there's this whole organization that combines the management and information of a number of these practices. And I think making primary care attractive to attract nurses, to attract young GPs, as you showed how that goes down. I think we need flexibility in the system. And that is important because if you would ask professionals what they find important, it's three things. The first thing is that they want to do where they were educated for. They want to do their work in a good way, and that requires flexibility and autonomy. They want to have a decent pay, not a very high pay, because otherwise they would have been working in a completely different sector, but they want decent pay, and they want to do something for the common good. And there the learning system comes in. In my view, professionals like to be in a learning system to improve the system. Collaboration is also very important for attracting new nurses and doctors. The collaboration is something which makes the work attractive. Development of special skills in this whole process of upskilling, skill shifting, task shifting, it is very important that people are allowed and supported to develop their skills. And as I said, the learning system. And for workforce policy, this means that we have to change the workforce policies from the head counts and as Ellen said, looking to the past and just put on the lines in a linear way. The policies that we develop in health workforce are very context dependent, in particular in primary care, which is in it basically context dependent. We have to go from single profession forecasting and policy to multi-professional team-based approaches. And we have to find ways of integrating skill mix innovation and task shifting and support and education for new professional roles in our workforce policies. This is all integrated in a huge scheme that it's difficult to read now, but it is in this policy brief that you can download. And that also ends my presentation.
Tiago, por favor. Very nice, Dr. Peter.
Okay. So good morning, everyone. Thank you for inviting me. Where's my? Can someone put my presentation up? Oh, thank you. How do I change? How do I? Sorry, how do I change this? It's not. It's not. Oh no. Oh, okay. Right. So many of you who work in primary care may not have. You're all familiar with WONCA Europe, which is a European scientific organization for family doctors, but many of you have not heard of UEMO, which is the political/professional organization for family doctors, and it stands for Union Européenne des Médecins Omnipraticiens, generalist physicians in opposition to specialist physicians. It's an organization that has been around for about 60 years. We are kind of the union side of things, so we defend the role of general practitioners in the healthcare system. We promote high standards of training and practice. Very importantly, we represent family doctors in European institutions, namely European Commission, European Parliament, and so on, and other international organizations. And we collaborate with other European medical organizations to strengthen the position of the medical profession. Now, we are comprised of national medical associations. Well, it could be, depending on the country, it could be national medical associations, it could be the medical unions, it could be the scientific society, so each country is different. Each country has to pay an annual fee. That's how we fund the organization, and we also fund the organization through accreditation of scientific events for family medicine. We also have a number of countries which are observers. So we do a lot of policy advocacy at the European level. Traditionally with DG Santé, which is the public health arm of the European Commission. Also with DG Employment, because of something else which I'm going to talk to you about. We also engage a lot with the European Parliament, particularly with the Sant Committee. You know, I'm an accredited lobbyist in Brussels, so I have a chance to easily go to the Parliament and speak to MEPs. We also meet with the cabinet of European commissioners, for the current health commissioner Varhelyi, and also, for example, recently we met with the cabinet of Commissioner Switska, which is the Croatian commissioner for. She's Commissioner of the Mediterranean, but also the Commissioner for Demography. And we saw how Anna Sofia spoke about the importance of medical demography. And we are active stakeholders in agencies such as the European Medicines Agency, Health Technology Assessment, Health Emergency Preparedness, which was an agency that was created during the pandemic. We are members of a new organization, an informal organization called the European Alliance for Primary Care Workforce, which convenes not only UEMO, but also WONCA Europe, European Forum for Primary Care, and other organizations. We also engage with other European medical organizations. There's maybe 10, 15 of them. Other international organizations like the World Health Organization, for instance. And of course, we also try to increasingly engage with national authorities and national medical associations, because we actually think that's how we can mostly affect change, which is engaging at national level rather than European level. Now, last year I gave an interview to an Italian Italian newspaper, and I surveyed all our member organizations about the number of GPs that are needed in each country. And this is not only at EU level, so it's also non-EU countries like North Macedonia, Serbia, and so on. Now, in Spain, they need about 5,000 family doctors. In the UK, they need about 30,000 family doctors. It's a disastrous situation right there. In Italy, Sweden, even a country like Sweden, you'd think, beautiful country excellent country to be a family doctor in terms of working conditions and job satisfaction. They need about 5,000 family doctors. And even in a country like Norway, which usually tops the charts of professional satisfaction, they still have a substantial thousands of patients without a family doctor. So the problem is not only in Portugal, the problem is European. And of course, it's actually global, but we'll stay within Europe for now. Now, these are the policy recommendations that I'm always trying to convey to politicians around Europe. Now, these are the traditional ones that you'd expect, and I would call your attention to the last two ones. One, greater exposure of medical students to family medicine. This is essential. Actually, I was trying to meet yesterday, but I arrived too late, with Jan de Masseneer. He was here. I spoke with him last week. I was trying, let's try to meet up at the conference, but we couldn't match. And in his medical school, he told me, in his medical school, 50% of medical students go into family medicine, which is impressive. And that's because the whole medical degree is formed around family medicine. Most of the professors are family doctors, so the students are grown within an environment, very family medicine centric, right? Okay. And the other issue I want to raise awareness is the need for the European recognition of the specialty of family medicine, because you think, well, in Portugal we have the specialty of family medicine for, 40 years or more than 40 years. In Spain, in France as well, but not at the European level. The European Commission does not recognize family medicine as a specialty. Okay, so for European decision makers in Brussels, we are like a second class field. Okay, now, we are not an academic organization, but we've done our own survey of our members. In the different European countries, GPs can have list sizes from as little as 600 patients to as much as 3,500 patients. I think it's in Turkey. GPs do 10 to 15 consultations per day. Have 15 to 25 minutes per consultation, usually have list sizes below 1,600 patients. Now, that's less than the average list of a full-time GP in Portugal, okay? And we asked them what is considered a manageable workload. It's working less than 8 hours a day, having a list size smaller than 1,600 patients, having long consultations, and having less than 25 consultations per day, which is considered the safe practice thresholds. Now, this is a figure that was developed by the Spanish Medical Association, so that the equivalent of our Ordem dos Médicos here in Portugal, the Organización Médica Colegial, and they published this infograph, which I think is brilliant. And they divide basically policies in positive policies and negative policies, and they're also the neutral policies. But I'm just going to focus on the positive and negative policies. And the problem, in my view, the problem is that politicians, and I'll say this about Portuguese politicians, which is the reality I know the most, politicians, particularly Portuguese politicians, tend to focus on the negative policies, the policies that don't work, okay? Like, in Portugal, politicians love to use the last strategy, deploying doctors without residency training to fill up places in primary care, okay? So using what we call in Portugal undifferentiated doctors, rather than, having very skilled and qualified doctors. Also, in other countries, things like increasing residency placements, increasing supply, thinking that by increasing supply you're going to improve the workforce, which is also a policy that our politicians here in Portugal love to invest in, but it doesn't work, because if you don't improve the working conditions, you're not going to improve retention. Now, also using final year residents to cover gaps. This is something we do in Portugal in certain areas of the country, but we don't invest enough in positive policies, the ones that are more likely to work. Things like awarding permanent contracts. This is not a problem in Portugal, but it is, for example, in Spain. Flexible working arrangements. This is a huge problem in Portugal with our very rigid public system, making it difficult for family doctors to work part-time. Housing, for example, the fact that NSV has said about the problem in Lisbon has a lot to do with housing. You have Portuguese salaries, but London costs of housing, right? Providing financial incentives. This is something we do well in Portugal. We provide financial incentives to family doctors. Access to research and continuous medical education. It has a lot to do with what Peter said about the learning system, access to additional training in additional skills, things like that, okay? Now, I invite you to go to our website, www.wemo.be, and download this policy statement we have on how to recruit and retain young doctors in general practice and family medicine. Now, I want to talk to you a little bit about the recognition of a specialty of family medicine. This is something very few people know about. Now, family medicine is recognized nationally in most EU member states, but not at the EU level, because the legislation that mandates the recognition of professional qualifications, Directive 2005/36, lists GPs separately to specialized doctors. So for the European Commission, you have specialized medicine or specialized doctors in one list, in one table, and you have what they call general medical practitioners in another table. So this is it. On the left, you have the table, which is I'll tell you the technicality. It's the point 5.1.4 of the Annex 5, and lists the qualifications of European GPs. So basically, if I'm a Portuguese GP and I want to work, say, in Ireland, they'll go to the list. Ireland will check the list. We'll see if my qualification is in that list, and it will automatically recognize my qualification. But the specialized medicine is in a different list. So basically what we want is to have family medicine included in this list, in the 5.1.3, okay? Now, we are also developing a European training requirement with the support of the European Union of Medical Specialists, because the European Union of Medical Specialists is the organization at European level that develops curriculums for the specialties. There is not a European curriculum for family medicine, but we are working on that. But that is work mostly being led by Wonka Europe and EURACT. But we are supporting that, and that is essential. If we want to be recognized as a specialty, we also have to have a European curriculum. It makes sense. Now, one thing. Now, okay, why am I showing you this? Because so this was in 2024 when Pope Francis was still alive. And Pope Francis endorsed the World Family Doctor Day, which is coming up next week. It's on Tuesday, May 19th. This was almost exactly 2 years ago, and he endorsed the campaign of the World Family Doctor Day. So we had a chance to go to the Vatican and meet him, and he gave a speech about that he had a family doctor when he was a child, and so on. So we increasingly need public figures, celebrities. It could be, this is the Pope, but it could have been, George Clooney, Dua Lipa, whoever you might think. And I think it is very important to have increasingly celebrity, because having a celebrity endorse general practice and under-recognized specialty is more important than me going to Brussels every week to lobby politicians. It's much more effective. Now, finally, here are some take-home ideas. Now, so we are a great brand. We know all of us who are in the field know that we are a great product. But we have a huge marketing problem. We don't know how to sell our fields. Now, so I think after having heard the three previous speakers, I think it's pretty obvious that we're not an attractive career, and this is regardless of income or working conditions. Now, for example, France, they have huge incentives to attract family doctors to work in deprived areas, what they call medical deserts. They give you tax-free salary, they give you a house, things like that, but they still can't attract doctors. So we have to go beyond the income and working conditions theory. So we need like a new career project, more in line with what Peter was saying, And I'm going to say something that may be controversial. That I mean, if you put, and this is the problem in Portugal, you know, you put family doctors working 35 clinical hours or 40 or whatever, and that's not sustainable. Family doctors should not be working, if in a 35-hour week, you should not be putting family doctors doing more than 20 clinical hours. Your time has to be just going beyond, has to be spent in things other than seeing patients. Otherwise, you're going to burn out. You're going to lose your motivation. You need to do other things, because family medicine is, you know, it's a difficult business. You know, it's hard work. You know, it's intense. You're there dealing with the same people throughout their life. You know, so in hospital you get away with it because you only see patients throughout a part of their life, and especially if you have difficult patients, they're going to stay with you for the rest of your career because you provide longitudinal care. So it's very you know, it causes huge strain on your mental health. Now, from my experience dealing with European Commission, European Parliaments, decision makers all over Europe, they don't know hardly anything about family medicine. So that's why it's important to engage with them. You know, you'd be surprised that we have less lobbying capacity than nurses and nurses and pharmacists, for example. They have full-time lobbyists in Brussels. The family doctors, we do not have full-time lobbyists in Brussels, and that limits us a lot. So, you know, I go to Brussels maybe 10 times a year, but I mean, you would need people like me full-time there every day. Now, the recognition of the specialty is not seen as relevant by the European Commission. I've had many meetings with the DG Employment, which is the employment arm of the European Commission, and they don't see the need to change the legislation. Because the legislation already allows mobility. So why of family doctors? So why change things? But you know, we in the family medicine profession, we know that it's important to change that because of, you know, 50 years ago, it made sense to have this distinction, but not anymore because the specialty has evolved. It's a specialty in most European Union countries. You know, we have strong training, we have strong academia, so we fulfill all the criteria of a specialty. So there's a basic sense of injustice here that the European Commission does not understand. We need better data. Now, we found, I mean, if you've seen Desafio's presentations, you know, it's very basic. Now, the thing about the Pope, you know, we need family medicine key opinion leaders and influencers, you know, endorsing our specialty. And I'm pleased to say that next week, which is Family Doctor Day on Tuesday, World Family Doctor Day on Tuesday, we're going to have a member of Portuguese band endorsing, we're going to release a video of in collaboration with APMGF, the Portuguese Scientific Organization for Family Medicine. We're going to release a video of a member of a well-known Portuguese band endorsing family medicine, and we want to continue doing that. You know, focus on positive policy. So if there's one thing I don't know if there are any politicians here in the audience. I think there are because I'm seeing some. You know, I want you to focus on positive policies. That's my main message here. So we have the European training requirement for family medicine in the pipeline. I'm hoping that we'll still have it approved this year, but I'm being optimistic. And we have to keep going in terms of lobbying, because politicians know very little about family medicine. And I apologize if I really if I really didn't give a good impression about politicians today. I apologize. No, most of you are nice people, but you need, but you need to know, you really need to step up and gain awareness, because we are the biggest group of doctors. And Desafio has shown that we are the biggest group of doctors in Portugal, in Europe, but we are not punching above our weight. We are actually punching under our weight. We are not actually we are what, 25% of doctors. 27% of doctors in Portugal, so we're almost a third of doctors in Portugal, but our weight is not being visible, is not visible, okay? So, I'm trying to change that. Thank you.
So, believing that Dr. Ellen is still with us, I must thank you highly for your brilliant presentations, all of you, because you just turned my mission a lot easier. You pointed the data, the lack of it, the inequities, the importance of governance, the different models, and some ways to achieve it. So we have, unfortunately, a lack of time. I have a challenge for the fourth of you. In 1 minute, please point us how to make family medicine sexy and desirable again. and one priority measure to put it on the map of health policy and of the system. Thank you. So, Dr. Ellen, can I begin with you, please?
Thank you. I would say improve gender inequality and listen to the needs of the healthcare workers, the family doctors and nurses, and respond to that. Thank you.
Thank you. Dr. Ana, please. Yes, yes.
Está a funcionar?
Tá.
Tá?
Tá.
Bom, I believe that in Portugal we are still a bit far behind some of the things that Tiago pointed out regarding. I mean, we already have some incentives for instance, family doctors, but we still do not have a policy directed to primary care that is innovative and that endorses all professionals involved in primary health care. So I believe that investing in collaboration, but also still in infrastructure investment, because we still have many inequalities in terms of the working conditions, the physical working conditions in which professionals have to work. And I believe that addressing those inequalities in primary care, I mean, bringing all primary care to a minimum level play field that is attractive for all those who work there, and also address these regional inequalities, because we have massive differences in such a short territory.
Thank you. Dr. Pitcher.
Yeah, of course, it's very difficult to say something in 1 minute that really makes sense, but I think one of the important things for primary care is a much more population-oriented and outreaching approach. In the past, a GP could say, when a patient doesn't visit my practice, I assume they're healthy. But that's not the case anymore with elderly people living longer at home. And during the COVID period, you saw that in very many countries, GPs, or I would not say GPs, but primary care teams became much more outreaching, finding the patients that should have been to the practice, for instance, for their diabetes, but didn't come because of being afraid of picking up the infection. But this outreaching that worked during COVID because of the crisis has changed again, because it is something that's not basically funded. So make the work attractive by funding what's to be done, not only just some services, but a population responsibility.
Thank you.
Okay. Well, as for making family medicine sexy, well, I've already gave a few clues. I think endorsement by public figures is important. I think we almost need like a PR public relations firm, to come and revamp the specialty. How many of you, how many series shows on TV are there of hospital doctors? Hundreds. How many are of family doctors? None. Because our care is not seen as glamorous. We're not seen as glamorous medicine. So I think that's why engagement with the whole, we have to reach the elites of society, because it's the elites that drive the trends in society. But elites probably do not resort to family doctors.
We had 2 of these series in the Netherlands, and that's why Dutch primary care is so good.
That's right. That's right.
So it works. It works.
Now, in terms of one measure, well, if it was in Portugal, if I was speaking just for Portugal, I would say flexibility of the profession, because I think without flexibility of the profession, the numbers in the curves in Anasfia's slides are going to continue to fall. Okay, nothing is going to change. It has to do with the feminization of the profession. Women do not want to work 35, 40 hours a week as family doctors. I'm sorry. That's pretty obvious, but the government still thinks. And we also have to rethink our own profession. Our profession is still eminently seen as a clinical profession. You know, it's not seen as a, I think, you know, hospital doctors tend to look down on us because, you know, they see it as a second-class specialty because our specialty, you know, they don't see us as a very academic specialty, you know, we don't do research and publish papers. No, so, you know, but give us protected time for that, okay? So we need to offer, you know, a continuous learning environment. The government is not concerned about the continuous medical education of family doctors, you know, so that you can be continually upskilling throughout your career and gaining new skills, like Peter was saying. Thank you.
Thank you. Ellen Kuhlmann, Tiago Anueva, Peter Grundwegen, and Ana Sofia Pereira. It has been a real, absolute pleasure. Thank you so much for your contributions. Thank you, and have a nice night, nice day. Thank you so much. Thank you.